CAR T therapy has changed the game in cancer treatment. But what happens when the game changes again and a patient relapses? Whether it's after early line or later line CAR T, a relapse can leave patients and clinicians wondering, what now? Are bispecific antibodies the next step? Can you get CAR T again? Or should you be considering other treatment options? In this Health Tree University lesson, we're breaking down the evolving landscape of post-CAR T treatment options, from retreatment strategies to where bispecifics fit in, and what current data and clinical practice are telling us. What treatments could patients consider if they relapsed after a CAR T that was given after 4 prior lines of therapy?
In 2025, most of our patients relapsing after CAR T received that CAR T after many lines of therapy, which will be different than patients who relapse after an early CAR T. So I think that's one difference we need to recognize. So patients who've kind of seen everything, then came to CAR T, still will usually have had, 1, 2, 3, maybe 5 years of treatment-free time. And so they're generally then have all of the therapies available to them again. So we recycle therapies that maybe have worked well. So anything that gave that patient a remission for 18 months or longer. And in general, in our small studies that we've done with our patients, we've shown that another T-cell redirection tends to be better than any of the old traditional chemotherapies. So while, say, a bispecific may not work as well after CAR T than in a patient who's never had anything targeting BCMA, in a patient who's had a BCMA CAR T, nothing will work as well as a bispecific. So a few caveats, we do have now bispecifics with 2 different targets. So being able to target GPRC in place of BCMA may be helpful. But years after the CAR T, usually that relapse, the patient will have BCMA expressed and so would be able to get a bispecific targeting BCMA.
Let's say somebody has had a CAR T, right? So what can we do next? Can they receive a bispecifics? So absolutely, if somebody has failed a CAR T in later line and they've seen a lot of the drugs combination, they might have had a transplant, they've seen a lot of the drugs that we commonly are able to use and have used. Generally, the new immunotherapies are available. Like I mentioned, bispecifics certainly are an option, including the BCMA bispecifics, but also the GPRC5D bispecifics. And we have a lot of clinical trials in development. We have different targeted CAR Ts. We have combination of bispecifics with other drugs, whether it be with daratumumab, pomalidomide. We have trispecifics coming down the pipeline, and we have CELMoDs and combination. And we have dual targeted CAR Ts, multiple ongoing clinical trials with those. So, the future has not looked so bright. There are multiple clinical trials and newer targets being developed in clinical trial, and hopefully will come into practice soon.
What happens if a patient has relapsed on both CAR T and bispecifics?
CAR T, is a cellular therapy. It does its job and they kind of leave and you're done. Bispecifics requires the T cells be continuously engaged. So many times if you're relapsing after a bispecific, it's due to T cell exhaustion. Like these cells, you just don't have T cells ready to keep doing the work. So they're 2 slightly different scenarios. But we certainly can then go back to the earlier therapies, which they may have received in different combinations. So putting them together in different ways. Another thing we've done quite a few times for patients who are still eligible and maybe still have stem cells is to do a stem cell transplant, not so much for the myeloma therapy, but really as a way to reboot the bone marrow so that you then have healthy T cells or healthier immune system and the rest of the microenvironment so that they then will respond better to pretty much any of our therapies.
What is a stem cell boost?
Sometimes we can use a stem cell transplant or what we call a stem cell boost. That is not quite so much chemotherapy, but bringing in stem cells to reboot the immune system so we now have all of the parts of the immune system functioning. And maybe the T cells that were exhausted due to prior BCMA bispecifics can now be present and be activated, and now we can repurpose the previously given bispecifics.
PACE-based therapy is a strong combination of chemotherapy drugs used for myeloma that isn't responding to other treatments. The PACE drugs are cisplatin, doxorubicin, cyclophosphamide, and etoposide. Sometimes other medications are added to this base to make the treatment even stronger or better suited to a patient's disease. It's typically used to control aggressive myeloma or as a bridge to other therapies and is given under close medical supervision. Is there any role for PACE-based therapies?
That's to me an emergency brake. So whenever the myeloma is growing a little too fast and we may be in danger of harming kidneys or bones or in general are in a rush to turn it around, I think the DCEP and PACE combinations still have a role. It's just we don't ever expect those to last very long, so it really is a step to get them to something else. It's not a therapy in and of itself.
Relapsing after CAR T therapy doesn't mean the end of the road. It means it's time for a new strategy. Whether it's bispecific antibodies, clinical trials, a second CAR T, or a whole new approach, the landscape of options is growing, and so is the hope. As we learn more about how to sequence and personalize these therapies, one thing becomes clear. The future of myeloma care is adaptable, evolving, and increasingly patient-focused. If this video helped you understand what's possible after CAR T, give it a like, share it with someone who might need it, and make sure to subscribe for more insights into the next wave of precision treatments. Thanks for watching, and remember, knowledge is power, especially in the fight against cancer.